Yeah, thanks Yvonne for the kind introduction. So I would like to present you some work that we are doing at the MGZ in Munich, which is a human genetics department, and we have a strong diagnostic background and also a lot of sequencers in our facilities to basically analyze any kind of heritable diseases and do clinical reporting together with our doctors and also doctors across all Germany. And my point here is about liquid biopsy, where we are putting this also into clinical praxis, and I'll talk a bit about pitfalls and requirements if you want to set up these kind of liquid biopsy approaches. So first of all, liquid biopsy, what is that all about? And in the moment, the field of liquid biopsy is mainly important for cancer genetics. And here you have a distinction of a liquid biopsy versus a tissue biopsy. And you probably all know this, that the tissue biopsy can be hard to obtain. If you are having the possibility to obtain a biopsy, which is an invasive procedure, you can sequence the tumor and find biomarkers or variants that are associated with potential clinical interventions, targeted drugs, and so on. However, it's not always possible to retrieve such a biopsy, and or it's unwanted by the patient, or you cannot reach it easily. So an alternative for getting information about the tumor is the so-called liquid biopsy. And this is based on the principle that basically all cells in your body secrete small DNA fragments, and also the tumor does so. So you have cell-free DNA that is circulating in your blood, and some of this DNA is coming from the tumor. So you can detect tumor markers in the liquid biopsy, so in the serum of a patient, and you can do this, for example, in a serial session that you take biopsies over time, and you can also think about it in a way to cover more of the tumor heterogeneity that may be in place if the patient has more than one metastasis, for example, which is not necessary or of the same genetic makeup. So the idea here is to take blood and to filter out circulating cell-free DNA, and then look for variants that may be informative for the tumor. And if you look at it on a time scale, let's say from left to right, this would be, for example, an example of a cancer patient with a tumor. At diagnosis, you would have a tumor, and you would have circulating tumor DNA in the plasma at a low level, and then maybe the oncologist decides for a treatment. Maybe the tumor grows a bit further until surgery, then the bulk of the tumor is removed, and accordingly also the amount of cell-free DNA coming from the tumor is reduced, or you do have some tumor left that you cannot really detect by classical imaging facilities, for example, but you still could detect a minimal residual disease using the cell-free DNA or circulating tumor DNA. Then you would, for example, have at some point a recurrence, have another treatment decision, tumor grows, you have a response for this new treatment, and so on. So the basic application of circulating tumor DNA detection can be either here at the beginning, before cancer occurs for screening, but more importantly also to detect minimal residual disease, response or resistance to treatments, and also over time during various treatments. As I said, the trick is here to define the circulating tumor DNA based on cancer-specific alterations. And you can do this basically using targeted ctDNA analysis approaches. Either you can use a highly specific and cost-effective ddPCR method that detects single variants in a PCR reaction, or you can take an NGS approach where you use a targeted NGS panel and try to identify tumor-relevant variants in the NGS assay. So what we're doing would be, for example, either you look at a tissue biopsy, you extract the genomic DNA, you fragment it to make it analyzable by NGS technology, or you take liquid biopsy, you extract the circulating cell-free DNA, which is already fragmented to some degree, and its specific also fragmentation profile if it's coming from the tumor. And then we would use a so-called duplex approach where you ligate certain adapters to the DNA and amplify it so that you get a very high coverage of the ctDNA and a highly specific information on the variants that you may detect in the liquid biopsy. So you would do basically the sequencing, and what we are using then is VARVIS as a pipeline for the bioinformatics to detect the variants and to call the variants. And during my talk now, I would like to first go into a bit more detail how cfDNA looks like, and later on give you a bit more in-depth overview of how duplex ligation, how the assay works, and then about the pitfalls that may arise if you are implementing or trying to validate ctDNA assays in your laboratory. So first of all, as I said, this is a fragmented DNA that is secreted from tumor cells. So if you look on extracted cfDNA, you have a certain insert size distribution. And if you look at patient samples here in green, then you see that there is a strong peak here around 170 to 180 base pairs. This is a typical size distribution of circulating tumor DNA from patients. So if you want to implement such an assay for yourself in the diagnostic lab setting, you want to be sure that you are having reference materials also that may be similar to such natural distribution of insert sizes. And here you have a comparison of 3 reference materials from SenseID, Coriell, and SeraCare that we tested in our lab during the establishment of the assay for their similarity. For example, here you see that a similar distribution can be seen with the SeraCare reference material, but that the SenseID and Coriell materials are a bit more widely distributed, and this is actually a hint that it might be a good idea if you want to validate your cfDNA extraction methodology in the lab, that you should make sure that the reference material that you're using for it is close to the patient situation. So what you do then with the cfDNA that you extracted, or in our case, we use duplex consensus building approaches, which is basically a tagging method where you have amplicons for the genes of interest with markers on the plus and the minus strand of the DNA, here depicted by alpha and beta. And then you have basically the picture that you see here, and the green variants or the green dots here may represent a true DNA variant from the tumor that you find in many of the reads that you are actually looking at, but you also find random reads here depicted in blue that are potential artifacts from the library preparation steps. If you would just look at the raw reads here, you would have basically a lot of variants that would be called that are noise and that you want to get rid of. So in this approach here, you would collapse basically all of the same duplex sequencing sites based on their tags to reduce the noise already and to collapse a lot of sequencing data into consensus reads, by that reducing the amount of false positives. And if you then take a step further and combine the plus and minus strand tags, you basically filter out all the noise and only the true tumor variant remains that can be called here with a very high sensitivity, because you use a lot of sequencing reads on the same position, and it's also very specific because you don't have the noise. And this is actually quite important to determine the performance of your liquid biopsy assay. For example, here in the terms of a limit of detection, which is a representative of 95% sensitivity for the assay, and also more important, as I will continue saying in a few moments, is the limit of blank, where you have the assumption that you have a 5% false positive rate and a 5% false negative rate, so that you can really be sure about what you are detecting is actually a variant and is not a noise. So the noise would be here left to the variant allele frequency that you set as a limit of blank. And then, if you want to apply this also in a quantitative manner, you would have to determine a limit of quantitation, where you actually would be sure that any quantitative changes that you detect in a serial measurement of ctDNA would be true changes, and you could have an idea whether a tumor actually, or whether you have more ctDNA in the blood than on the previous state of blood extraction or not. So you have the limit of blank, which is critical, for example, for residual disease detection. If you're above it, you are sure that you detect something that is real. And the limit of quantitation is a measure that is important for treatment monitoring, for example. And if you bring this back to the clinical picture, what you really want to have is a low limit of blank, because for the patients here that may or may not have a minimal residual disease, it's really important to go down to very low allele frequencies to be sure if there is a minimal residual disease in the boundaries of the assay or not. So what we had a look at regarding the noise that I showed on the picture before is that we also compared the different reference materials that we were dealing with in certain bins of variant allele frequencies. And here you can see on the left hand a bin of very low allele frequencies, and you can see that in one reference material, the Seracare variant material, we have a very, very high number of, in the medium, 3,000 variants with a very, very low allele frequency. And this, such variants are also present with a higher allele frequency. And these these variants would all not be present in the other tested reference materials. And actually, when you go to a variant allele frequency of 1 to 5%, where the patients actually show up with allele frequencies, you still have a lot of background in this serochem material. So at this point, you can depict it also in a slightly different manner. So on the x-axis here is the variant allele frequency that goes from 0 to 1 here in this case. And what you want to have is actually a limit of blank at the very low end of the variant allele frequency. But it's quite tricky to get this if you have a lot of noise in your reference material. And if you compare this to the other two materials that we tested, there is much less noise at the lower end. And actually, this is similar to, this lower bar here is what you see in actual patients. So the patients actually, they present with a comparable number of low frequency variants. And this can be really a problem if you want to be sensitive, if you only use one material and not the other two. If you calculate then, for example, the sensitivity or the positive predictive value of your assay based on these three different materials, you would have a completely different picture of what you're getting. If you set the limit of blank for 0.1% of a variant allele frequency, you would have almost 100% sensitivity and a high predictive value already if you use the two materials that come with low noise levels, but it would be completely useless if you would use the material with the high noise background. And the same is true also for the slightly higher variant allele frequencies. So using this comparative approach, we were able to push our limit of blank actually from 0.5 to 0.1 variant allele frequency and make it much better than before, just by finding the right reference materials to validate the assay with. And so that we have, in the end, quite a high sensitivity and positive predictive value for each patient for this particular assay. So, summarizing the opportunities and pitfalls here, again, you can use one material, basically, if you are developing your experimental protocols, and you can use it very well, but you rather should not or may not use the same material also for determining your limit of blank, where you could rather use the other two materials. So this is really a careful step to select the available commercial reference material for your assays. So what we are using this for at the MGZ is basically to try to solve cases of cancer and also to apply it to patients with overgrowth syndromes that may carry also variants in cancer-related genes and come with mutations that may be very well known from cancer already as activating or inactivating. So here we, for example, have cancer cases where we did ctDNA analysis, where we found a couple of interesting variants with actually quite low frequencies or even higher frequencies depending on the tumor burden in a set of well-known cancer genes. And we also can apply this for the mosaic diseases, finding PI3 kinase and KRAS variants with a very low frequency and facilitate the diagnostic for kids that are in a young age and not really happy if you would try to pinch out a bit of their overgrowth skin, for example. simply by using ctDNA assay and using their blood. So overall, we have like 50% of cases where we find an interesting variant that we can report, and we have so far a span from 0.1% to 17% of variant allele frequencies. Thanks to this whole elaborated workflow, starting with the laboratory work, but also the highly efficient bioinformatics platform that we're using from Varvis. So in the moment, there are basically three areas where liquid biopsy is going to be in clinical practice more or less in the next couple of years. So one hand, you have the possibility to guide treatment decisions in cases where, for example, the biopsy is not possible, where you don't want to wait 6 weeks or longer for the analysis of FFPE tissues, or where you have a low quantity or quality of the DNA tumor biopsy. You can basically try to find information about the tumor from the liquid biopsy. Then, as I mentioned, you have the possibility to detect minimal residual disease or recurrence of a tumor and make a decision based on the presence or absence of ctDNA in the blood, whether you want to put a patient on chemotherapy, for example, or rather not. And on the other hand, if you are treating the patient already with a targeted approach, you may monitor the treatment success and identify progressive disease, or probably also variants that are associated with the resistance to a certain therapy. And with that, I would like to thank you all for your attention. And if you have any questions afterwards at the Q&A session, I'm happy to answer it, or just drop an email to either Dr. Hallermeyer or me for further information. And I would also like to thank the Varvis team for their support in this work. Thank you very much.
Any question that you would like to ask now?
What do you use for determine your limit of life? Is it just a wild type DNA?
No, it's actually it's a genome in a bottle. Yeah. So these three reference materials are all based on this material.
Did you do any orthogonal conformations?
Pardon?
Orthogonal conformation, the variant you take from the pipeline, do you conform by another technology or anywhere?
You mean if we tested it with orthogonal approaches? I'm sure we did for the establishment of the duplex sequencing, as we are using both the ddPCR and the duplex sequencing, and we started with the duplex sequencing. So I'm pretty sure that we did orthogonal validation here.
Any idea since how much is the concurrence rate?
No, I don't have this data in mind in the moment. Sorry.
Okay. Thank you, Thomas.
Okay, thank you.